Done. Done.
Yes, sir. Good afternoon, everyone. On behalf of Ahmedabad Family Physician Association, a warm welcome to all the dignitaries and viewers. Today on Zoom meeting with us, three eminent speakers from SCG Cancer Hospital, Dr. Kaustubhai Patel, Dr. Aditya Yoshikura, Dr. Dushanbhai Mandlik, and as a moderator with us, Dr. Mehul Selar. The today's topic is on the thyroid cancer, and first of all, I invite the first speaker, Dr. Dushanbhai Mandlik, and the topic is epidemiology and diagnosis of thyroid cancer. I described the brief introduction of Dr. Dushanbhai Mandlik. He is a consultant in head and neck and reconstruction services at SCG Cancer Hospital, Sola. He did his MBBS and MS from Reputed Institute in Ahmedabad. He has trained extensively for post-oncosurgical reconstruction. He received special training from the Department of Head and Neck from famous institute in Kochi, Kerala. He has keen interest in microvascular free flap reconstruction, giving functional importance in his modality. He has presented many papers and reputed national and conferences. Now I request Dr. Dushanbhai to start his talk on epidemiology and diagnosis of thyroid cancer. Dr. Dushanbhai.
Thank you, Devendra Bhai. Thank you, Mehul Bhai. And thank you, AFPA, for giving us this platform to share our thoughts on thyroid cancer. We will today go through thyroid cancer in a sequence. My talk will center on thyroid cancer's epidemiology and diagnosis of the same. So again, I thank Ahmedabad Family Physician Association. This is the team, surgical team, Astha Oncology Associates, which we are at HCG Ahmedabad. We are more than 20 surgeons now dedicated to subspecialty. If we see about thyroid cancer, then it is not something which is very recent. Though people were not knowing about it, the thyroid cancer was there before many years. In old excavation, you can see that this statue has an enlarged goiter in the neck and a scar also. So from 1000 to 1861, there is a long span from a prehistoric era to Biliroth's thyroid surgeries. The thyroid management has evolved. Talk or a quote about by Samuel Gross on the system of surgery of the thyroid was in 1866, like no honest and sensible surgeon would ever engage in thyroid surgery. The outcomes of the surgery and treatment were so dismal that people, and especially surgeons, avoided thyroid cancer. But slowly in 1867, the antisepsis was evolved, and Biliroth restarted the thyroid surgeries, and after that Coker invented more techniques about the thyroid surgeries, and slowly it became a popular surgery with good outcomes. So two Nobel laureates basically made a big difference in thyroid surgeries. They were Theodore Biliroth, and Biliroth taught Coker, and Coker was the one who actually mastered the thyroid surgeries. No doubt that legacy passed on to Halsted, who actually reversed a lot of surgeries, a lot of techniques, and he really developed the art of thyroid surgeries. If we see about the incidence, the cancer incidence is rising throughout the world. But as you can see in this graph, the thyroid surgery incidence is rising very much in ahead. If you see here, all the surgeries, including all the cancers, including cervical cancers, they have a falling kind of a pattern, where the thyroid cancers has an increasing pattern. But at the same time, if you see that the numbers of thyroid cancer are increasing, but the mortality is remaining almost similar to what it was. That says that even though there are a lot of thyroid cancer patients, but they survive. So if you give a good treatment to them, they do good. Usually we come across these four kind of thyroid cancers. They are papillary and follicular differentiated thyroid cancers and medullary thyroid cancer, and one of the worst is anaplastic thyroid cancer. It is said that a well-differentiated thyroid cancer in a majority of the part gets cured, but a small part of them, around 10%, may develop recurrences also. But the mortality is very, very rare, which is less than 2%. As you can see here, is in differentiated thyroid cancers over the period of 20 years, you can see the survival is in the tune of 99 to 84%. What happens is that same differentiated thyroid cancer, if it is neglected, that goes on the genetic changes and goes to the bad variants like tall and insular cells, poorly differentiated carcinoma, and ultimately anaplastic carcinoma. So the survival rate decreases from 85% to 2%. Similarly, the mortality also increases. So we in ASTHA have certain aphorisms. I will come in between with those funny lines that in thyroid cancer or in any other surgeries, how surgeon evaluates. It's not just the thyroid cancer which evaluates, we also evaluate. And in initial 5 years, we learn how to do the surgery. In next 10 years, we learn how and when to do the surgeries. And ultimately, we learn when not to do the surgeries. Now, this is a big series of Memorial Sloan Kettering Cancer Center, and there are around 2,000 odd patients. And they evaluated various parameters like age, gender, histology, and size of the patients. And does there have an effect of those factors on the outcomes of thyroid cancers? According to that, what is the latest guideline now in American Thyroid Association is risk-based stratification of thyroid patients. So there are certain criteria like size, extent, grade, and distant metastasis, as well as age, which puts the person and the cancer in high or low grade or high or low risk factor. And according to that, there are 3 risk groups which are made. Like a low risk is less than 45-year-old female patient with less than 4 centimeter tumor, which is intragranular and which is low grade and no distant metastasis. Similarly, a high risk is more than 45-year-old male with more than 4 centimeter tumor with extragranular extension, high grade with distant metastasis. And a combination of in between in age is intermediate group. So now the thyroid cancers are treated and prognosticated more on this risk group stratification rather than just histopathology of the tumor. And you can see that in a good outcome, in a low risk, the survival is almost up to 99% over the 20 years. And in the high risk group, you can see that in the red line, it drops down to 57% over the period of 20 years. So whenever somebody comes with a thyroid nodule, everybody is perplexed that what to do with this nodule. Do we need to worry about it? Is it going to be a cancer? What we should do? A needle biopsy, sonography, CT scan, or how early we need to treat this patient? Is there an emergency? So if you can see, the most important thing or most important clinical examination is palpation of the gland. You can see that here there is a right-sided solitary thyroid nodule which was moving with deglutination. You also palpate neck for other neck nodes and other signs of metastasis. Now that swelling which is in the midline can be a thyroid also, there can be a lymph node also, there can be a laryngeal carcinoma also, and many more. So you need to now zoom down to your differential diagnosis. As you all know, the thyroid gland is situated in the neck around trachea, and almost 95% of the nodules in thyroid are benign nodules. Out of 5% which are cancer, most of them are well differentiated cancers, and less than 5% are anaplastic carcinomas. So these are the cornerstones of your reaching down to your differential diagnosis, which is your history, physical examination, risk stratification, structural and functional assessment of the gland. As you can see, the next important clinical examination is Optimus Recording. That is a telescope passed through in office endoscopy through the throat, and we see the vocal cords, because in thyroid cancers, because of the two reasons, we have to document the vocal cord mobility. One is the vocal cords are involved or not, and second, medico-legally also it is important to document vocal cord mobility because of other injuries which can happen during your surgery. So here you can see this is a normal laryngeal examination. This is base tongue, and now we are zooming on the vocal cords. As you can see, both the vocal cords are mobile, and this is kind of a normal examination which everybody will have. Now here you can see that the vocal cord movement on the right side is impaired. This is because there was a large thyroid mass which was sitting in the neck, which engulfed right recurrent laryngeal nerve. But as you can see, the vocal cords were approximating normal. Both of the patients were having normal voice, but because we recorded and did Hopkins examination, we came to know that the later patient had a compensated voice, and because of that, the voice was not changed, but the vocal cord movements were impaired. Now, do we need to do thyroid function test? I think the most prescribed test for any thyroid is thyroid function test. So there is an ATA recommendation for thyroid function test that you measure serum TSH first. And in initial evaluation, the serum TSH is the most important investigation of the blood which you do. If the TSH is subnormal, then you do a thyroid scan. There is a recommendation for that. But if the TSH is normal and elevated, you should not perform the radionuclide scan. You should go for other investigations. The another investigation which is very important is the sonography of neck, which is going to give you the characteristic of the entire thyroid gland as well as the characteristic of nodules. Now, there are certain characteristics which you pick up on your sonography that can tell that a nodule is cancerous or not. Here are the risk factors like punctuate microcalcification, hypoechogenicity, absence of halo, suspicious lymph nodes, etc. on the high risk side, and certain on the lower risk side. So your sonologist can actually tell you that how worrisome your thyroid nodule is. So there is one score known as thyroid score, which says that this cancer, how likely is this nodule, how likely it is going to be a thyroid cancer or something else. And always ask your radiologist whenever they do a sonography to give you a thyroid score to guide you further. It is from 0 to 7 points are allotted, and from thyroid 1, which is benign, to thyroid 5, highly suspicious, is categorized. Also, don't neglect other signs like fever, dry throat, neck pain, or diffuse enlargement on USG with capsular enlargement. That can be a Hashimoto's thyroiditis also. Now, you need to find out histopathological diagnosis, which is usually done with a fine needle aspiration cytology, which has a sensitivity of 95% and specificity of 68%. In certain cases where you are not sure or you need more tissue for your core diagnosis, a true-cut biopsy is also utilized. Should you do FNSE always? So NCCN guidelines says that certain nodules which are very small or which are not having a sonological feature of suspicion can be left alone for observation without doing an FNSE. So you should follow these guidelines and not prick each and every nodule to find out there is a cancer or not, which is not going to do much of the help. As you can see, we discussed about the sensitivity and specificity of the FNSE. But at the same time, when you receive a FNSE report, it has to guide you. Now, this type of a report, like cellular smear with multiple follicles at AFPA of intermediate significance, very follicular lesion, it is not going to help you. It's not going to put a diagnosis, or it's not going to help you to counsel your patient, even if it is a magnified lesion. So for that, you need to go for a system like a radiological thyroid classification. There is a Bethesda system of reporting of FNSE, which can characterize your nodule from a non-diagnostic, unsatisfactory benign nodule to level 6, that is malignant lesion. So you can be very much kind of clear about what you are going to counsel to your patient and what you are going to do with your patient, how you are going to manage it. Of course, the risk of malignancy differs from Bethesda 1 to Bethesda 6, which is from 1% to almost 99%. So in the almost all Bethesda 5 and 6, you are pretty sure that you are going to go for a surgical resection. As you can see here, from Bethesda 4 onwards, surgical lobectomy to thyroidectomy are the line of management. So always ask your pathologist not just to report FNSE, but give you a Bethesda category score. So what is if the Bethesda says it is non-cancerous? Even if it is non-cancerous, the surgery is advised in all the Bethesdas, which are more than 3. If the patient is anxious and is not willing for regular follow-up or observation, or there are compression symptoms or high-risk features on scanning or the demography or in the genetic markup of the patient. You need to order certain investigations like thyroid function test. As we discussed, again, based on the TSH, you rule out there is an hyperthyroidism or not. And according to thyroid functions, you can go for your differential diagnosis. When you go for a CT scan, when you feel that the nodule is big and the potential extrathyroid spread, or on ultrasound, you see that there are multiple lateral or central nodes which are positive. The nodule is extending below your neck in the retrosternal area. There is a questionable vascular relationship adherence, or the nodule is situated at certain areas which are dangerous, like posterior nodule or nodules near the recurrent laryngeal node. Now, there was a myth of using iodine contrast, not using iodine contrast in a thyroid patient, but now the studies have abolished that myth. Rather, you will a better identification and better characterization of the thyroid and thyroid nodule, and with that contrast and then CT scan, and it is very safe now. It doesn't hamper with your radioiodine treatment. So for a solitary thyroid nodule, it is a low risk. You can observe with 3D ultrasonograph, and most probably you will not need to repeat your FNSE. And in a high-risk patient, you evaluate more aggressively and go for a definitive treatment. Now, if there is a thyroid nodule, and can you observe that thyroid nodule? Yes, in selected cases, you can observe a thyroid nodule. If it is a very small nodule, even if it is a micropapillary carcinoma less than 1 centimeter, it is a well-differentiated cancer, located middle in the substance, and patient is willing for close follow-up, because they are usually very slow-growing tumors, and you can keep a tab on that by serial investigations. But the patient should be very well educated, and patient should come for follow-up very regularly. What are the types of surgeries? These are the types: hemi, total with central or lateral neck dissection. Remember that near total thyroidectomy or subtotal thyroidectomy is not the surgery for a thyroid cancer. It is something which should be abolished from the textbooks. Either you do a hemithyroid or a total thyroidectomy, because there are many problems with near total or subtotal thyroidectomy, which my colleague will elaborate. As it is very much rightly said, the decision is more important than the incision. Take time to evaluate your nodule, take time to evaluate the thyroid and the patient, rather than jumping and putting a neck incision and removing the thyroid in haste. So thank you. And my colleague Aditya will take the subject further from here. Thank you.
Thank you very much, sir.
Thank you.
It was a very nice lecture, sir. Now over to Dr. Aditya Yoshikura.
Yes, sir.
Sir, how are you? Dr. Aditya, how are you?
Yeah, hi, I'm good. I'm just here, so I'll be joining.
Dr. Aditya Yoshikura will talk on treatment modalities of thyroid cancers. Actually, Dr. Aditya Yoshikura is a student of VS Hospital and Civil Hospital, actually.
Yes.
He received advanced head and neck oncology from New York, USA. He is involved in endocrine surgical unit with a special focus on thyroid, parathyroid, and thyroid malignancy management. He is having active participant of the management of head and neck disease management at HCG Cancer Institute. He is a respected teacher, actually, to train our next generation at HCG. He is a founder secretary of Gujarat Cancer Society of Head and Neck Oncology. He is active member of Indian Association of Surgical Oncology and Foundation of Head and Neck Oncology. Dr. Aditya Yoshikura, please, he will speak on treatment modalities of thyroid cancer. Dr. Aditya Yoshikura. Thank you, sir.
Thank you very much for that generous introduction. So I'll be taking forward the topic of thyroid and thyroid cancers. As my colleague Dr. Mandlik very elegantly pointed out about the epidemiology and the starting part of the management of thyroid cancer. So now is where the confusion actually starts. This was the last slide that we saw, and I'll carry it forward right from here. There are various surgeries that are seen for thyroid, and anyone who comes in contact with us first asks us the same question, whether you should take out the half of thyroid, full thyroid, what about the neck dissection, etc., etc. So there has been a lot of effort and a lot of research going on to establish certain guidelines where we can definitely say the Bethesda and the Thyroid system, as Dushanbhai very correctly pointed out, are the ones that are our guiding forces towards the type of surgery that is to be performed. So a hemi or a total thyroidectomy are the only two thyroidectomies that exist. Neck dissections can be based on the need and the positivity as seen on the CT scans. As we saw the aphorism of Asta, that the decision is more important than the incision, and that is where our problem lies. A lot of you must have seen patients coming to you with Google reports of thyroid being enlarged and parathyroid, etc., telling you that he needs a surgery. But that is obviously not how we will be suggesting him a surgery. For a case of a proven well-differentiated thyroid cancer, the main data has to be aggressive at extremes of age. Like children less than 16 years will require a total thyroidectomy and radiotherapy, and older patients with more than 60 years of age should be treated to appropriate aggressive surgery, followed by radioactive iodine as necessary based on the histopathological report. In adults of in between ages, low risk unilocular, unifocal intraglandular tumor in all age groups can be treated with hemithyroidectomy, can being an operative word here. And in high risk tumor in all age groups, total thyroidectomy with an aggressive surgery is the best way to go. When would you do a unilateral or a hemithyroidectomy? As we can see, a tumor that is located in the single lobe of thyroid gland, or even multifocal tumors as seen on the figure on your right, in the single lobe of a thyroid gland, which are smaller in size, less than 2 centimeter ideally, can definitely be treated with hemithyroidectomy. There are certain surgeons who prefer hemithyroidectomy for tumors less than 4 centimeter also, and there are guidelines that support this kind of an argument too.
Excuse me, sir. So
Yes.
slide is not sharing now.
It's not sharing?
Yes, sir.
Oh.
Yeah, it is visible.
Yes,
So,
yes, now it is
is
visible.
visible or
Yes, yes.
Yes, yes. Do.
Okay. So
Yes.
I'll just go on to the next slide. So when should we be doing a hemothyroidectomy? A hemothyroidectomy, as seen in the figure, should be done in the cases where there is a small tumor or even multiple small tumors that are located in a single lobe of a gland. Less than 2 centimeters of size, a single tumor is a definite indication for your hemothyroidectomy, and even up to 4 centimeters tumors, single tumors located in a single lobe, hemothyroidectomy can be performed. Total thyroidectomy, again, those tumors that are located outside the thyroid gland, that is the tumors with extrathyroidal extension, multiple tumors located in both lobes of thyroid gland, tumors with lymphadenopathy, and multiple bilateral unibifocal tumors. These are the tumors that require total thyroidectomy without any question. Now, a total thyroidectomy, as I said, is a diffuse bilobar tumor, bilateral nodules, regardless of the size of the primary, extrathyroidal extension, massive bilateral nodal mets, distant mets, and history of radiation exposure. These are the indications, absolute indications of total thyroidectomy. Now, NCCN guidelines clearly suggest that lobectomy is possible in cases where there is no prior radiation, no distant mets, no cervical mets, and no extrathyroidal extension, with select cases of less than 4 centimeter diameter. This is the ATA guideline that we always follow. American Thyroid Association clearly states that for patients with thyroid cancer more than 1 centimeter, the initial surgical procedure should be near total or total thyroidectomy unless there are contraindications for surgery. Thyroid lobectomy alone may be a sufficient treatment for small micropapillary carcinoma that may be incidentally detected. But the key word here is before 2015. These are guidelines that are before 2015. The ATA version after 2015 clearly suggests to us that up to 4 centimeter tumors are amenable to hemothyroidectomy, and there's a whole new chapter regarding tumors less than 1 centimeter, which my senior colleague Dr. Patel will discuss. Main objectives of thyroid surgery are complete removal of one or both lobes of thyroid glands to preserve the blood supply of the parathyroid glands and to prevent injury to the nerves that are located in the area. Now, this is a very interesting thing that we can see. I'll just briefly share the video with you here. That's okay. So as you can see, this is the thyroid gland that is being medially rotated during the surgery, and we can see the parathyroid glands and the recurrent laryngeal nerve in picture. This is the pointer at the parathyroid gland, the inferior parathyroid gland that is seen very clearly in this picture. Now, lymph nodal dissection is not to be done in prophylactically in all cases of papillary and follicular thyroid carcinomas. Central compartment sampling is optional in proven cases with negative nodes. And if nodes are positive, then a proper formal central compartment nodal dissection is necessary. Now, why do we stress so much on the central compartment node dissection, whether we should do it or not? The question would be, why don't you just do it? The reason being, these slides are shown in the figure. As we can see that the parathyroid gland and the recurrent laryngeal nerve both lie within the central compartment, and when the central compartment is taken out, there is a definite risk of injury to the parathyroid gland and sometimes even to the recurrent laryngeal nerve. So this is the reason why we should be careful in doing central compartment, because there is a potential of injury to parathyroid. There is also a chance of bleeding because direct branches of the inferior thyroid artery come there, and there is a potential risk of thoracic duct injury. As we can see here, this is just a brief anatomical sketch. You can see the location of the parathyroid, superior and the inferior parathyroid, and the major vessels that are located in and surrounding the thyroid. These are the nerves that form an important part, and these are the ones that are functionally the most important ones. As you can see, the right recurrent laryngeal nerve and the left recurrent laryngeal nerve arching around the aorta and one going above the aorta to supply the muscles of the larynx. These are the two most important nerves that are necessary for preservation of the supply. Now, again, you would see what kind of an anesthesia would be necessary. as just a brief joke on that. Now, the important structures that are to be seen here in this figure are the superior laryngeal nerve, the external and the internal branch, and the blood supply to the thyroid. These are the important structures that need to be preserved while doing a thyroidectomy, because their inability to save them may lead to devastating complications relating to the voice. The parathyroid gland, as seen in the previous figure, if not saved properly, would lead to problems. You can see the superior laryngeal nerve that is seen on the artery photos, very nicely demonstrated here. This is the superior thyroid artery that is located in the top left of the screen, and the superior laryngeal nerve just hooping over there. This is the recurrent laryngeal nerve clearly entering the cricothyroid muscle. Cricothyroid muscle, that is cricothyroid region, right, in the Berry's ligament region. This is the parathyroid, the inferior parathyroid that is separated from the thyroid, and the rest of the specimen can be taken out. In the lower part of the specimen, in the lower part of the picture, you can also see the carotid vessels that are very, very prominent. Now, a brief video on parathyroid preservation, where the yellow structure is the parathyroid, and we are easily separating the parathyroid from the substance of the thyroid. The parathyroid goes down, the thyroid comes up. The recurrent laryngeal nerve, very faintly seen as a white structure below, is preserved, and everybody can go home happy. So at the end of the thyroidectomy, this is the picture that should be seen. This is a picture that clearly shows all 4 parathyroid glands at their adequate place. Both recurrent laryngeal nerves on both the sides are very nicely seen, and these are the major vessels that are clearly left undisturbed. Now, parathyroids are very, very important, because hypoparathyroidism in total thyroidectomies is either temporary or permanent, but every time it's very, very annoying and very, very disgusting. Temporary parathyroidism, hypoparathyroidism is seen in up to 25 to 30% of the cases, and permanent is seen in 2 to 3% cases. More chances are when central compartment neck dissection is added. It is clinically evaluated in the wards by Chostek and Prozio's signs, and it takes about 8 to 24 hours for the calcium levels trending to decide discharge. This is why the total thyroidectomy patients are never discharged on the day of the surgery, even though surgery might be safe. You never know what happens with calcium. So calcium levels should be assessed, and then they should be set. Now, an aphorism of AFPA that we often use is that the complication rate, it's directly proportional to the extent of the surgery and inversely proportional to the experience and training of the surgeon. So as we saw, it's anatomically in a very, very sensitive and a skillful area. So it requires a surgeon who is very used to these kind of very specific surgeries, preserving everything, and may not run into trouble at anything. Now, as you see, the risk of leaving behind thyroid tissue is significant, because a patient with thyroid cancer may require adjuvant therapy in terms of radioiodine and other things. And if there is thyroid tissue left, as seen in the dark gray areas on the figure on your right, on your left, then it is very, very difficult for radioiodine to work in other areas, because these tissues take up the entire radioiodine. On the right is a picture where a good pyramidal lobe dissection and all the lobes dissection has been done, and this is clearly suggestive that this has been taken out well. There you see, this is a thyroid with its sucraglandal tubercle seen on the left side, and a pyramidal lobe that is seen on the right side. Just to sum up, there is a rule of 2, which is another aphorism of AFPA. When you hear a surgeon telling his number of performed cases, divided by 2. And when he tells you about his complication rate, multiply by 2. These are the risks and complications, as I mentioned. Hypoparathyroidism in total thyroidectomies, temporary to permanent, injury to recurrent laryngeal nerve, which is seen in normally 1% cases. So the most important take-home message for the surgeon is, just because you can do an operation safely, it is never an indication that you should be doing that operation. Indication is always the appropriate operation for the patient with his risk stratification and classification. So as I said, the early postoperative issues and the late postoperative issues may be hemorrhage, hypothyroidism, and hypocalcemia, which usually are dealt with nicely. So as you see, this is a very skillful surgery that has a potential for a lot of complications. Now, how do we deal with it at our center? and what are the latest technologies available is something that I would look forward to Dr. Kaustubh Patel, my senior colleague, to be putting a light on. Thanks a lot.
Thank you very much, sir.
Yeah.
So it was a very nice lecture, sir. To all member of Ahmedabad Family Physician Association, I request you all to be a member of Family Security Scheme about our scheme. Actually, in this occasion of our Facebook Live of from SCG Cancer Center, the benefits on death of a member, his nominee has had paid fraternity contribution collected from the members of the scheme. Is a member. Permanent disability benefit member who has become permanently physically or mentally disabled, thereby rendering him unfit to practice his profession, will be eligible to receive all the benefits and shall not have to pay any further fraternity contribution or annual membership subscription. The permanent physical mental disability is subjected to confirmation by medical board. Any member of the unit who fulfills the eligibility criteria of the scheme, the units to which he belongs, his age under 65 years, or can be a member of this family security scheme. Spouse of the members can also join. This is the spouse of the member can also join our scheme. And important points of this scheme are after becoming the member, the benefit starts after the lapse of 1 year. The accounting year will be from April to March. Total number of days during the period. A member would be sent notice of payment his fraternity contribution every year by the month of April. He will be paying the same latest by 30th of June without any late fee. After that, penalty clause as decided by the constitution will start. You can contact Dr. Pragnesh, Dr. Dhiren, me, or anyone of our office bearer for this scheme. Thank you very much. Now, the legend, Dr. Kaustubh Patel. કૌસ્તુભભાઈ માટે એટલું જ કહીશ કે કેન્સર શબ્દને ખરેખર આનંદિત કરનાર જો માણસ હોય તો કૌસ્તુભભાઈ છે. બહુ વખત પહેલા મને યાદ નથી આવતી બુકનું નામ. સર, બુકનું નામ એક અમદાવાદ મેનેજમેન્ટ એસોસિએશનમાં એક બુકનું નામ આપણે
10 on 10.
યસ સર, સર. હું એટલું જ કહીશ કે કેન્સરને કેન્સલ કરનાર એટલે કૌસ્તુભભાઈ. કેન્સરના પેશન્ટોને ખરેખર આનંદિત કરનાર એટલે કૌસ્તુભભાઈ. વર્ષોથી એકબીજાના પરિચયમાં છીએ અને આપણા ફેમિલી ફિઝિશિયન્સ માટે કદાચ અમારે એકવાર મીટિંગ થઈ હતી મારે ને પ્રજ્ઞેશ સાહેબ સાથે. એમણે અમને એવું ખાસ કીધું હતું કે તમે લોકો સ્ટાર્ટ કરો તમારા ક્લિનિકમાં, અમે લોકો તમને પેશન્ટ મોકલીએ, તમે ફોલોઅપ કરો અમારા પેશન્ટ્સનું. અનફોર્ચ્યુનેટલી આપણે એમનું ફોલોઅપ ના કર્યું એટલા માટે. પણ હવે 100% આ સીએમઈ પછી સાહેબ 100% ફોલોઅપ કરીશું અને અમને શીખવાડજો કે અમે ખરેખર કેન્સર પેશન્ટોને કેવી રીતે ટ્રીટ કરી શકીએ છીએ. Thank you very much. Let's introduce Dr. Kaustubh Patel. He is a professor and senior head and neck oncologist, director Department of Head and Neck Oncology at HCG Cancer Center. He is a director of Astha Oncology Associates, FHNO National Institutional Fellowship. He was a president of FHNO for year 2017, 18, and 19. He was a founder secretary of Gujarat Society of Head and Neck Oncology, Ahmedabad. Published many papers, original research in numbers of national and international journals. Even keynote address and સાહેબ માટે બહુ બધું છે. સાહેબનો બાયોડેટા કદાચ આખી ફેસબુક લાઈવ આપણું પૂરું થાય એટલો બધો મોટો બાયોડેટા હોઈ શકે. પણ એક જ વસ્તુ જે બધાને અપીલ કરે એક જ વસ્તુ છે કે કેન્સરને કેન્સલ કરવું ને કેન્સરવાળા પેશન્ટોને મજા કરાવી. એમના મગજમાંથી કાઢી નાખવું કે ના ભાઈ તમને કેન્સર છે એટલે તમે તમારું જીવન પૂરું થયું, તમારું જીવન શરૂ થયું અને તમારા જીવનનું ભગવાને બહુ સારું કર્યું કે તમને કેન્સર આપ્યું એવું ઠસાવનાર અને ખરેખર સાબિત કરનાર જો એક જ માણસ હોય તો એ ડોક્ટર કૌસ્તુભભાઈ. આઈ રિક્વેસ્ટ ડોક્ટર કૌસ્તુભભાઈ પટેલ સ્ટાર્ટ હિઝ લેક્ચર. થેન્ક યુ સર. યસ સર.
Thank you so much, મેહુલભાઈ. તમારો મારા માટે બાયસ છે મને ખબર છે, અને I'm sure કે અમદાવાદના મોટા ભાગના physicians એ bias share કરે છે અને I am really grateful for that. આજે આપણી જે આ થાઇરોઇડ માટેની CME જે આપણે કરી છે એનું કારણ એ છે કે આ મહિનો જે છે this month September month is actually known as a thyroid cancer month. And that is the reason why we thought about putting up thyroid. What I would like to discuss would be what are the recent advances and technologies in thyroid cancer, because what has happened is કે હવે પેશન્ટ્સ બહુ હોશિયાર થઈ ગયા છે, એ લોકો ઇન્ટરનેટ ઉપર ઘણું બધું વાંચીને આવે છે, they are updated. અને એટલે જેમ આદિત્યએ કહ્યું એમ કે એ લોકો કદાચ ઘણીવાર સેકન્ડ ઓપિનિયન લેવા આવે છે ને પહેલો ઓપિનિયન તો એ લોકોનો ગૂગલ પાસેથી આવી જ ગયો હોય છે. ફોર્ચ્યુનેટલી હજી કોઈ એપ શોધાયા નથી કે જે ઓપરેશનો કરી આપે, એટલા માટે હજી આપણી પાસે એ લોકો આવે છે. આ આસ્થાની ટીમ છે અને જેમ દુષ્યંત અને આદિત્યએ કહ્યું એ પ્રમાણે there are aphorisms of Astha which we will share. There will be few aphorisms which I will be repeating in my lecture which they have already shared. Thyroid cancer is fastest rising cancer incidence in human. આ USA ના figures છે અને ઘણા બધા cancer decline ઉપર છે, પણ unfortunately thyroid cancer is on the rise. અને એના ઘણા બધા reasons છે, પણ bottom line એ છે કે thyroid cancer ની mortality over so many years has remained very low. And that is because there are effective treatment available for this thyroid cancer. And that is the reason why many a times in our internal discussion we say કે એક જ cancer ભગવાન આપવાનો હોય તો let's take thyroid cancer compared to any other cancer. And Dushyant, the way he showed that there is up to 99% cure rates in younger age of patients, we sometimes discuss that thyroid surgeons patients, they live longer than thyroid surgeons, and that is the first aphorism I would like to put up today. Now, having said this, there is one recent advance which is very important. Non-invasive follicular thyroid neoplasm with papillary like nuclear features is a name given to a cancer which was previously considered cancer, and now this has been eliminated from the nomenclature of cancer. So this is the first time in the history where a cancer has become benign. And this is the reason because people have extensively searched and extensively followed these lesions which were previously considered to be thyroid cancer, and now it is considered to be benign because none of the patients usually die of this cancer. So that is the reason this type of nuclear features, whenever they are there, they were considered to be cancer previously, now they are not. And many people have researched and gone back to those slides and blogs and again talk to the patients that sorry, we said that you had cancer but you don't have a cancer, and that has definitely made a difference to the patient's psychology. Another advance which has occurred is micropapillary thyroid carcinoma. When a papillary cancer is less than 1 centimeter in thyroid lobe, these Japanese people are very innovative. So there are Japanese researchers and thyroid surgeons who decided that let us follow this cancer because this is 99% curable cancer. Why don't we follow them? Don't do surgery. What happens? Let us see. And then the people in Japan also were quite agreeable to this kind of research work. And they followed thousands of patients with less than 1 centimeter size of papillary thyroid carcinoma, and they could see that only 10% of these patients had a tumor which grew. There were less than 4% who needed intervention, and the risk of death was less than 1%, one patient out of 1,000 patients on observation. So that's why the micropapillary carcinomas management has changed. There are criteria of microcarcinoma where you can follow these patients. There are few microcarcinomas which are high risk, which we consider high risk because of their characteristics, and then we offer them surgery. Otherwise, we always give them option of observation. And that's the evolution of surgeon, that at a certain age, with experience and understanding the biology of the disease, you understand that when you don't need to operate. And this is the bottom line, that the good physician treats the disease, the great physician treats the patient who has the disease. And that's why just naming a papillary cancer doesn't mean that you have to remove it. You are treating the patient, you are not treating only cancer, you are treating a patient who has this cancer. Now let's go to the complications. Now, the most dreaded complication of thyroid surgery is voice change because of the injury to recurrent laryngeal nerve. But many people do not know that external branch of superior laryngeal nerve is equally important, and especially important in teachers, people who have to speak a lot, singers, all these people, because this external branch of superior laryngeal nerve supplies cricothyroid muscle, which is extremely important for the pitch of your voice. And that is the reason injury to this can create problems which will be evident in people who are using their voice very specifically. And that's why you can see that this is the branch, which is an external branch, which is going, this is the external branch which goes like this. And if it is not seen properly or identified properly while removing this thyroid lobe, which it crosses over the thyroid, this happens sometimes. And if you don't identify it, you might cut it or injure it, and then the patient can have problem. The recurrent laryngeal nerve, of course, everyone knows that is a very important nerve. All the muscles of the larynx except cricothyroid are supplied by recurrent laryngeal nerve, and that's the reason why there is a vocal cord palsy if the recurrent laryngeal nerve damage occurs. What is important is that there are many variations described of recurrent laryngeal nerve. There can be branching, there can be two branching, there can be three branching, there can be a recurrent nerve anterior to inferior thyroid artery, posterior to inferior thyroid artery, can be in the tracheoesophageal groove, can be lateral to esophagus. So all these, and also a non-recurrent laryngeal nerve on the right side. So all these are the anomalies of recurrent laryngeal nerve, and if you are not aware of it, you may injure it during the surgery. So as Aditya showed, this is the recurrent laryngeal nerve, this is carotid, these are parathyroids, and this is the thyroid. But you need to identify, and not only identify, you need to check that it is functionally normal. And that is where intraoperative neuromonitoring comes into picture. It facilitates the identification and location of recurrent laryngeal nerve. It facilitates the exposure and dissection of recurrent laryngeal nerve. It facilitates the judgment of the functional integrity and warns of injury of the nerves. What is this technology? There is an endotracheal tube with a sensor which goes into the larynx, and there are sensors which are in contact with the vocal cords, right and left vocal cords. And this entire connection, this is the recurrent laryngeal nerve fiber, and this is the probe. So when you stimulate the nerve, there will be a conduction which will be detected by these sensors, because the vocal cord will transmit it, will move, and then this is reflected onto this monitor with a graph. So it's a device where there are different kind of stimulations described, which if you do, you will ensure that your nerve is all right. See, this patient has a thyroid with two nerves, and you can see this probe which is touching the nerve, and there is a clear-cut noise which comes, which gives us indication that these are intact recurrent laryngeal nerves. So any structure you just put a probe and understand that whether this is nerve or something else. So that is the way you are in a much better position to preserve that nerve. And you can also decide whether the integrity of nerve, recurrent laryngeal nerve is a branch of vagus nerve. So what you can do is you can stimulate the vagus and get the sound. Then when you are doing a thyroidectomy, you can stimulate that part of the nerve and get the sound. And once your lobe is removed, if you again stimulate the vagus nerve, you will know that entire tract of recurrent laryngeal nerve is intact and you have not injured. So, and it is seen on the monitor like this, a graph comes, this is a right vocal cord. So right recurrent laryngeal nerve, when I put a probe on that, there will be a graph like this. It will show the amplitude also. And you can have this record also, which can go into patient's file, so that it is medico-legally also very important to have this. And in USA, it is if the patient goes to court for a recurrent nerve injury or a vocal cord change, there is a strong possibility that if the surgeon has not used the nerve monitor, he can have problems in the suit. So when you must use this, if there is a large goiter, if there is a recurrent or redo surgery, if there is a retrosternal goiter, if there is a suspected non-recurrent laryngeal nerve. So all these situations, you use this, but we use it for all cases at our place. And we have now more than 400 cases where we have used this neuromonitoring successfully. Why we use it? Because we want to give the best outcome efforts to all our patients, because in surgery, surprises can come anytime. However simple surgery you would have expected, there can be a surprise at least in 1% of patients, and you don't want to have that surprise giving an inferior quality of life to your patient. So the aphorism of ASTA is, of course, the complications are directly proportional to the extent of surgery and inversely proportional to the experience and training of the surgeon, and would like to add that the technology being used. So what happens, how you manage the nerve injury? Intraoperatively by prevention, by using nerve monitoring and proper magnification. For treatment, if you need to cut the recurrent laryngeal nerve, if it is going through the cancer, then you can do a microneural reanastomosis and try and see to it that the nerve regenerates. And post-operatively, in patients who have come with vocal cord paralysis, you can do a thyroplasty, which is again a small surgery, but it can medialize the vocal cord, as Dushyant showed in one of the patients where the vocal cord was paralyzed, but the voice was normal. So the same kind of situation you can generate by medializing that vocal cord and getting it opposed to the normal cord, and the voice can become normal. Now, the second advance which we can talk about is of the incision. People don't like the incisions in the front of the neck. Of course, there are patients who have very good skin crease incisions, and healing, once they heal well, it is almost not seen. This is our anesthetist on the right side, and the left side is one of the VIP we had operated. But everybody is not so fortunate. So if healing is not absolutely 100% predictable in all cases, so those patients who do not want an incision in the front of the neck, we can do some other maneuvers like robotic surgery, like endoscopic resections, or like endoscopic assisted surgeries. The most common robotic thyroid surgery is done by either transaxillary approach or retroauricular facelift approach. We at our place use retroauricular approach because there are many advantages of doing even the node dissection with that, which is difficult with transaxillary approach. This is the robo which is used. There are robotic arms. You can see all the three robotic surgeons over here at our place. And what happens is that this is the breast approach, this is axillary approach, and this is a retroauricular approach by which the robotic arm goes in and we remove the thyroid with adequate margins. And this is the scar which happens. And it is, once the hair grows, the scar becomes invisible. It is retroauricular and in the hairline. So what happens is that this can be used as a facelift also, because this will stretch all this tissue up if you want it in a patient who is a little more aged and want it. There is one approach which is known as transoral approach for dissection of thyroid. So I would definitely say that this is not indicated for cancer, or whenever there is a possibility of cancer, you are not supposed to take this approach, because it creates a lot of spillage and it can create recurrences of this cancer. I'm sure there will be these kind of approaches coming up in future. We can have a transrectal thyroidectomy maybe 10 years from now, but every approach must be evaluated very seriously with evidence-based incidences and evidence-based approaches, so that it gets established as a robust level 1 evidence in management of thyroid cancer. So in surgery, the best instruments are fingers, as they are connected to your brain. And that's the reason why we do robotic surgery. It's not the robot who does the surgery. Our fingers on the console moves the tiny arms, and those arms are reflected into the robotic arms, which are going inside the patient. So it's not an artificial intelligence in the sense that robot is doing that surgery. It is the surgeon who is doing the surgery with his fingers, but there are many advantages of 360-degree rotations, magnification, 3D, and minimal incisions, which comes into picture to give a better quality of life to these patients. The last concluding aphorism of ASTA is that rule of 20. Only 20% of the people will remember 20% of what you say after 20 minutes of your lecture. And that is the reason why these are my numbers and email ID. Feel free to contact me for any clarifications on this lecture or any other help. Thank you so much.
Thank you very much, sir. It was a very nice lecture, and I am sure that બધાને બહુ જ ગમ્યું હશે અને બધાને ખૂબ મજા આવી હશે. Questions 100% પછી લોકો દેખીને કદાચ અમને કરશો તો અમે તમને 100% ફોરવર્ડ કરીને એનો આન્સર મેળવી લઈશું.
Yes, Mehul, we have a question. Yes. What is the criteria for the diagnosis of follicular thyroid carcinoma versus adenoma?
I think this is the question which Dr. Dushyant should answer.
Yes. Sir, what is the criteria for the diagnosis of follicular thyroid carcinoma versus adenoma?
Okay, so as I covered in my slides, thyroid cancer no primary diagnosis FNAC that is final aspiration cytology. So there are specific diagnostic Bethesda criteria. So if there is a certain architect in FNAC, it will say that it is adenoma. In certain architect, it will say that it's a follicular cancer or something else. So rather than putting a final diagnosis, it should be a Bethesda scoring system which will tell you that what it is. The final diagnosis definitely comes after you remove the gland and you get the diagnosis of a benign adenoma versus a follicular adenoma or follicular carcinoma. But at the same time, nobody should attempt to do an open excisional biopsy to have a diagnosis. That is a pure no-no. In any of the thyroid lesions, there should not be an excision biopsy done at any time.
Sir, one same type of question is that how to differentiate the diagnosis of benign thyroid tissue and metastatic papillary carcinoma in cervical lymph node?
Okay, so when a thyroid cancer metastatizes, it goes into the lateral cervical nodes. Either it is a central cervical node or it's a lateral neck node. Now, what happens certain times that the thyroid tissue overgrows itself. They are known as remnants, or in certain terms, it is known as accessory thyroid also. What happens is that the thyroid tissue grows, and at certain point of time, the stalk of the native thyroid and that lateral thyroid tissue snaps away, or it is very flimsy. So when you go inside, you find that there is a separate nodule there. So that becomes a aberrant thyroid or a separate thyroid nodule. But at the same time, if during your FNAC or during your surgery, you send that nodule and your pathologist says that this nodule is showing lymphatic architecture and is showing tissues of papillary thyroid carcinoma, it is not the thyroid tissue, it is your lymph node. That entirely changes your management. So frozen section at certain point in thyroid cancer operation is very important.
Sir, is the anti-thyroglobulin level a reliable marker of tumor recurrence or metastasis when TG level is low?
So thyroid cancers can be followed up in two ways. One is your biochemical follow-up. For a well-differentiated thyroid cancer, when you follow that up with thyroglobulin, serum thyroglobulin, it is a very good marker when you have done a total thyroidectomy. So we usually wish that the thyroglobulin level is either 0 or almost undetected following your thyroid surgery or following your thyroid treatment, and you serially follow your thyroglobulin level. But at the same time, when you draw the blood, you do your anti-TG antibody levels also. So if your anti-TG antibody levels, anti-thyroglobulin antibody levels are within normal limit, then the interpretation of thyroglobulin is good. It gives you a good guideline. But with a high anti-TG antibody, the importance or the reference value of the thyroglobulin changes. You cannot 100% rely on that thyroglobulin if anti-TG antibodies are high. So to adjunct to your biochemical marker, there should be always an anatomical marker. So we go for serial sonography, clinical finding, and as and when required, sectional anatomical imaging also.
So one last question is total thyroidectomy done in which type of thyroid carcinoma?
I think, sir, you will like to take it.
So what is the question? Total thyroidectomy?
Sir, total thyroidectomy done in which type of thyroid carcinoma?
Right. So Aditya clearly showed that when differentiated thyroid cancer, you have an option of hemithyroidectomy. When the tumor is less than 4 centimeter or 2 centimeter and the opposite lobe is absolutely normal and there are no lymph nodes involvement or there are no extra thyroidal extension. So these are the criteria. If it fits, if it is a well differentiated thyroid cancer, you can do a hemithyroidectomy. All other cancers like medullary thyroid carcinoma, poorly differentiated cancers, undifferentiated cancers, all these cancers requires total thyroidectomy. With a caveat that anaplastic cancer, even though you are able to do a total thyroidectomy, you should be very careful because these cancer patients, they do not live long. So, and most of the patients will come in advanced stage. So when we consider medullary thyroid carcinoma, it is always minimum surgery is total thyroidectomy with central compartment node dissection. And for tumors which are more than 4 centimeter in one thyroid lobe, you have to do a total thyroidectomy. If opposite lobe contains some lesions, you don't know whether that is cancer or not. It can be a multicentric papillary thyroid carcinoma. So that's why you do a total thyroidectomy. One more answer I would like to add to what Dr. Dusyan said for follicular adenoma and follicular carcinoma. FNAC is an important point. It will guide you for the chances of cancer. Meaning that if your pathologist says that it is Bethesda 3, then the chances of cancer is less than 15%. But if it is Bethesda 4, then in that case, the chances is 30 to 35%. So all these things will guide you how to manage this patient? Ultimate answer is final histopathology report.
Yes. Yes. Sir, I have read one sentence like skintigraphy. So what is skintigraphy?
So thyroid scintigraphy is again this iodine or technetium scan. That is a scintigraphy.
Yes, sir.
It's a nomenclature used by some people as scintigraphy.
Yes, sir. Dr. Mehul bhai. Dr. Mehul bhai.
Bolo, Dhiren.
Have you any question? Sir?
No, I have no question.
Then I start about start for the vote of thanks.
Please.
Yes, yes. So thank you, Doctor. My special thanks to all the three eloquent speakers, Dr. Kaustubhai Patel, Dr. Aditya Yoshikura, and Dr. Dushan Manlik, sir, for their elaborative and lucid talk on the thyroid cancer. And thanks to Dr. Mehul Sela, sir, for joining with us as a moderator. And I am also thankful to SCC Cancer Center, Sula, Ahmedabad, for sponsoring this webinar. At last, thanks to all the AFPA and GSFPA members for attending the live YouTube webinar. Jai Hind, Jai AFPA. Thank you very much to all.
Thank you so much, AFPA, and all the dignitaries on this webinar.
Yes, sir.
Thank you.
Thank you very much, sir.
Thank you, sir.
Thank you.
Thank you.